Hi students, today we are going to see a topic that is induction of labor. So you know that the normal pregnancy totally, if we are seeing, it has got three stages: pre-labor, cervical ripening and labor. So first pre-labor, the period before the labor, then the cervical ripening and the exact labor. The endogenous prostaglandin, the hormone, it plays an important role in all this process during the pre-labor part as well as in cervical ripening and as well as in labor. The one hormone that is prostaglandin, which is produced endogenously, that have a great role in all these processes. Okay. The intervention to artificially ripen the cervix, induce uterine contraction and augment labor. Once it is progress, also lack distinct boundaries. So in order to ripen the cervix, in order to induce the uterine contractions. So once if it is progress, then it has got some limit. Okay. So we will see in detail about what is induction of labor. The induction of labor, it is the artificial initiation of the labor mechanism prior to its spontaneous onset. So you know that once a lady become pregnant, so she will be given a date, that is EDD, expected date of delivery, and expect that the labor will start spontaneously by that time on that DEDD. Around that the date of delivery, expected date of delivery, around that period we expect that there will be onset of labor. But if it is not happening or prior to the spontaneous onset of normal labor pain, in induction we are initiating the labor mechanism, that is known as induction of labor. Once again, I will repeat: induction of labor means for every woman, once she will become pregnant, the doctor will be giving her by calculating through Nagel's rule or by after the USG, she will be given a expected due date. Okay, expected date of delivery. So we expect that she will have a spontaneous onset of labor pain around that period. So before that, prior to that, if we are artificially, through many ways, artificially, if we are initiating the labor, then it is known as induction of labor. So the induction of labor means, in the definition, the induction of labor means initiation of uterine contractions after the period of viability by any method, medical, surgical, or combined, for the purpose of vaginal delivery. So this definition includes everything. So what is induction of labor? Here what we are doing, the simple term we said that we are initiating the labor mechanism. So initiating the labor mechanism means we are initiating the uterine contraction, and when after the period of viability. So the EDD period will be that period is that by that time the baby will achieve all the viability. The baby will be independent. It will be able to survive independently, extra uterine. So after the period of viability, we are initiating the uterine contractions. There are various methods. It can be medical or surgical or combined. And our purpose is to conduct the delivery vaginally. So that is the definition. Induction of labor means initiation. Initiation, you can understand what is initiation. We are starting it. It is not there. There is no uterine contraction, but we are initiating it. There is another term which is known as augmentation of labor. That means already there is uterine contraction, but it is not sufficient. So we are just accelerating. We are speeding up the uterine contraction. That is augmentation of labor. Whereas the induction of labor is initiation. It is a very important term in the definition of induction of labor. We are inducing uterine contraction, or we can say it is initiation of uterine contraction after the period of viability. So many methods can be used, medical or surgical or combined, and ultimately our aim is to conduct the delivery vaginally. So that's the definition for the induction of labor. Next, it is a next purpose. So when we will think about the induction of labor, if the continuation, if the pregnancy is continuing, then if there is any risk to the mother or fetus, then we can move forward for the induction. If the pregnancy is continuing forward, then that will risk the life of mother or life of the fetus. In that case, we can go for induction of labor. Okay. Then various indications. If the mother is having any hypertensive disorders, or she is having diabetes or renal disease or any chronic pulmonary diseases, if she had premature rupture of membrane, or there is RH isomionization, or postdated pregnancy, or abruptio placenta, IUGR, IUFD, oligohydramnios, polyhydramnios, unstable life, then fetal congenital anomaly. So in all these cases, we can go for induction of labor. Okay, so these are the various indications where we can perform induction of labor. Any hypertensive disorders, the diabetes, if the baby is a IUGR or there is IUFD, or oligohydramnios or polyhydramnios, or the membranes has ruptured prematurely, or RH isomionization, or it is post-stage, the EDD has crossed, that postdated abruptio placenta. In all that cases, we can go for induction of labor. Now the contraindication, in which all cases we are not supposed to go forward with the induction of labor. Okay, we just now we have discussed about the indications when we can do. Now we are doing in which cases the induction should not be done, like contracted pelvis and CPD. Okay, then malpresentations, previous classical cesarean section, hysterotomy, uteroplacental factors such as unexplained vaginal bleeding, vasa previa, placenta previa, cord presentation, cord prolapse, any infection like active genital herpes infection, HIV, pelvic tumor. In all these cases, induction of labor is contraindicated. Okay, so contracted pelvis and CPD, you are aware about this condition. So here in this case, normal vaginal delivery is not possible. Malpresentation also it is not possible. If the mother is having, and previously she had classical cesarean section, means upper segment cesarean section, hysterotomy. Previously, some uterine operation surgery has been done, or some placental factors, vasa previa, placenta previa, or any infection, genital infections, HIV, pelvic. In all these cases, induction of labor cannot be done. Now, before inducing labor, some factors we need to assess. Okay, maternal factors are also there, even fetal factors. So in maternal factors, we have to confirm the indication. We have listed many indication in which induction of labor can be done, in which it cannot be done. So we have to confirm the indication. Then we have to exclude the contraindication. Then Bishop score. This is a scoring system. It is also known as uh, it is pre-induction scoring system, cervical scoring system, that we will be studying in the next slides. So Bishop score, and we have to assess a pelvic adequacy. These maternal factors we need to assess before the induction of labor. We have to confirm the indication, we have to exclude the contraindication, we have to assess the Bishop score, we have to assess the pelvic adequacy. Okay. Then in the fetal factors, we have to ensure the fetal gestational age, then fetal weight. The baby should not be macrosomic. Then we have to ensure the fetal presentation, malpresentation should not be there. We have to confirm the fetal well-being, we have to confirm the lung maturity. So all this thing we are supposed to assess in both the maternal and fetal aspect. We have to assess before doing the induction of labor. Okay. Now this is the Bishop score. It is very important. So now this, here you can see there are several parameters. As we said, it is known as Bishop's pre-induction cervical scoring system. It is modified one. Okay, Bishop's pre-induction, before induction, cervical, we are scoring it whether we can move forward with the induction of labor. So by this Bishop scoring, we can identify whether we can perform induction of labor to this person or not. Okay, so first thing, in the cervix, we will see the dilatation. Okay, so if it is closed, the scoring will be 0. Then if it is 1 to 2 centimeter, 1, 3 to 4, 2. If it is more than 5, the score will be 3. And whereas in effacement, you can see effacement is recorded in percentage. If it is 0 to 30, 0, 40 to 50, 60 to 72. Then if it is more than 80, then 3. Then we will see for the consistency of the cervix. If it is firm, 0, medium 1, then 2, soft. It's the same thing, 3 score. Then we will see the cervical position. It is posterior, 0 score, midline, anterior. Okay, then next. So this was about the cervix. You have to note one thing. Previously, as we said, that it is modified one. So previously the effacement was there, but in 1991 by the modification, this effacement has been replaced with cervical length. Okay, we have removed this effacement with the cervical length in centimeters. So here you can see the length. If it is more than 4 centimeter, then 0. If it is 2 to 4, then 1. If it is 1 to 2, then 2 is the scoring. If it is less than 1, the 3 is scoring. Okay. Now the head, we will note the station. If it is minus remains, it is above the shield spine, more above the shield spine, minus 3, then minus 2, minus 1 or 0, then plus 1, plus 2, 3. Okay. Now the total scoring is 30. So if the scoring is between 6 to 30, then it is favorable score, means we can proceed with the induction of labor. But if the score is in between the 0 to 5, then it is unfavorable. We cannot move forward with the induction of labor. And this is the Bishop score. It is pre-induction cervical scoring system. It is modified one. So there are several parameters: cervical dilatation, cervical effacement, cervical consistency, cervical position, and station, head station. Okay. Whereas in the modified Bishop score, the effacement has been replaced with the cervical line. Okay, so this is about the Bishop scoring. So the favorable score is 6 to 13. If it is the score which we got is in between the 6 to 30, we can proceed with the induction of labor. Okay. Next, we will see, as we said, there are, uh, as we said in the first slide, we said there are three processes: pre-labor, the cervical ripening, and labor. So in the cervical ripening, there are various methods where in which we can induce or we can initiate the cervical ripening. There is pharmacological method and non-pharmacological method. So what is cervical ripening? It is what happens during the labor. As the labor will, before it onset, what happens there, several biochemical changes will be happening at the cervix, and that will make the cervix to ripen. It will become soft, so it will become ripen. So here there are various methods for the cervix to get it ripen. The pharmacological medicines we can use like prostaglandin, then progesterone receptor antagonist or oxytocin or relaxin or hyaluronic acid or estrogen. Any these methods, any one of these method can be used for the cervical ripening. The most commonly used is prostaglandin, like misoprostol. You may be knowing misoprostol we will administer orally or vaginally, like pessary it can be done. Okay, or vaginally the tablet can be kept. Okay, so this was most common in the farm. This is a different pharmacological method in order to ripen the cervix. Okay, next the non-pharmacological method. The first one is the stripping the membrane. In the next slide we will deal about this stripping the membrane. Then transcervical balloon catheters, amniotomy, and dilators. Amniotomy is a rupture of membrane. Okay, then transcervical balloon catheter. This will also be discussed in the next slides. Then dilators. You know what there are different dilators are available, so that we can use in order to ripen the cervix. So these are the different non-pharmacological method to ripen the cervix: stripping the membrane, amniotomy, transcervical balloon catheter, and dilators. Okay. Next, we will see first one, as we said, that transcervical balloon catheter. We just in the usually what it is done, we will insert the Foley's catheter. Okay, Foley's catheter will be inserted intravaginally, and we will inflate the bulb. Okay, by using 30 ml fluid that will be instilled into the uh, balloon of the catheter, and that will be inflated. And what will happen, you can see here, it will exert the pressure directly on the cervix, which responds by cervical ripening and dilatation. You should know that any little changes at any some biochemical changes or any stretching of the cervix can lead to the liberation of prostaglandin from the cervix. Okay, so this can lead to cervical ripening. So if we are inserting a Foley's catheter and if we are inflating the balloon, what happens? The cervix, that balloon, that pressure will be exerted directly over the cervix. Okay, and now then how the cervix will respond? It will lead to the cervical ripening and the dilatation. So slowly the cervix will get dilated and cervix will get ripened. Understood? This is one of the mechanical method for cervical ripening. Okay, transcervical balloon catheter. Okay, next we will see the different methods. As we discussed ripening, in the ripening we said that stripping of membrane, transcervical balloon catheter insertion, amniotomy, and dilators. All this, so stripping of this transcervical balloon catheter, it is for the stripping of, that is for the ripening of the cervix that we have discussed. Now, whatever we said, point out the method that we discuss in this. Okay, as we said in the definition of the induction of labor, we said that there are various methods: medical, surgical, and combined. So these are the various methods for the induction of labor: medical method, surgical method, and combined. Medical, surgical, and combined. Both the medical and surgical will be used in combination. So that is combined. Okay, we will go in detail in each one. So now, in which cases we can use the medical case, in which method, in which case we can use surgical, in which case we can use the combined. We know, actually we know the indications, several indications we studied in the previous slides. So now we will see the medical method of induction of labor will be used in intrauterine fetal death or premature rupture of membrane. Even even this, in this two method, even we can combine it with the surgical induction. Okay, if it is IUFD or PROM, we can even combine it with the surgical. So combination method can also be used in this two method, in these two conditions. Surgical method, this surgical method is being used in abruptio placenta and chronic hydroamniosis. Okay, and even in severe preeclampsia and eclampsia. So most commonly the surgical method is used in hypertensive severe preeclampsia or eclampsia, chronic hydroamniosis, and abruptio placenta. And this combined method is used in order to shorten the induction delivery. If we are using both this method together, then the induction delivery interval will be shortened. After induction, it will take some time for the delivery. Okay, so in order to reduce that time, we can use combined method. Both this method we can use along together in order to shorten the induction delivery interval. Medical method for, so what we can do, we can start with medical method and then follow with the surgical method. Otherwise, first we can start with surgical method and then followed by medical. Anything can be done here. So these are the different method: medical method, surgical method, and combined method. Okay, now, so in the medical method, there are mainly three medical methods. The first one is, these are the different drugs used for the induction. First one is prostaglandin. Both the PGE1 and E2 can be used. Oxytocin and mifepristone. Prostaglandin E2 and PGE1 and E2 can be used. Oxytocin can be used, and mifepristone. Okay, we will go in detail about each of them. First one, prostaglandin. We know that there are three varieties of prostaglandin: PGE1, PGE2, and PGF2 alpha. But for the induction of labor, we will be using E1 and E2. E1 is the misoprostol. You are very much, I think you are very much aware about this misoprostol. You might have seen the words the mothers have given with the misoprostol tablet. Okay, orally or vaginally it is being kept, given to the mother. Then PGE2 DINOPROSTONE, that is Cervical. Okay, now we will move on. So the PGE1, that is misoprostol, dose of 25 microgram. Actually 100 microgram tablet is available most commonly, so that we will 1/4 of that tablet will be given. 25 microgram is given every fourth hourly, and maximum of 6 doses can be given intravaginally. Understood? Intravaginally, to 25 microgram can be given every 4 hourly, and maximum 6 doses can be given intravaginally. Then dose of 50 microgram every 3 hourly orally can be given. This also maximum 6 doses can be given. It is 50 microgram, vaginally 25, orally 50. Now, even 25 microgram can be given orally, but the every 2 hours. Here it was 3 hours, here it is 2 hours. Now, not only orally and vaginally, there are other routes also: buccal route, rectal route, and sublingual route. All this route can, through this all this other different routes for the administration of PGE1 or misoprostol. Okay. Now, As we said that there are different route of administration, we are just comparing with the oral, and these two are the most commonly used. We will see which is better, okay, or whether oral, we will see the differentiation. If we see the oral, it is less effective. If we are comparing it with the vaginal one, it is more, vaginal is more effective than oral, okay. And in oral, the fetal distress rate is less, but whereas in vaginal, there is more chance of fetal distress. Understood? So the vaginal method, the effectiveness will be fast, more effective, whereas it can cause fetal distress more. Okay, but in oral it is less effective, but the chance of fetal distress is less. Now, next one is the DINOPROSTONE or PGE2. Okay, here vaginally 0.5 mg can be given intracervically. This I think you know Cerviprim jelly. It is available. Cerviprim jelly syrup gel, it is available. 0.5 mg can be given intracervically, and even it can be repeated after 6 hours for 3 to 4 doses if it is required. Then even tablet form is also available. 3 mg we can give. We can keep it on the posterior fornix. After that, 3 mg can be given, and maximum dose of 6 mg. Then even pessaries are available, that will release the dinoprostone 10 mg over 24 hours. And after that, if cervical ripening is adequate, then we can remove that pessary. Understood? So PGE1 is misoprostol that can be administered orally, vaginally, buccal, rectal, and sublingually. And dinoprostone, it is a gel. Okay. Cervicrum jelly, that is most commonly used in many hospitals. It is being used jelly. It can be given, or even vaginal tab are available, or vaginal pessaries are available. Okay. Now, we will compare the misoprostol and dinoprostol. If we compare it with both, misoprostol is cheap, and but it is cost effective, whereas the dinoprostol is costly. Okay. Now, misoprostol we can keep at room temperature, and even it is easy to administer. But dinoprostol, it needs refrigeration. Understood? That is the difference. We can, if we are comparing, misoprostol is very, it is cheap and cost effective, and it can be, it is stable at the room temperature, and it is easy to administer. Okay. Next, oxytocin. So you know about the oxytocin. It is an endogenous uterotonic agent. It stimulates the uterine contraction. You know about all this thing. It acts upon the myometrium. In myometrium, there are oxytocin receptors, and the oxytocin receptors are more in the fundal region compared to the cervical region. Okay. And this concentration, if we see the oxytocin receptor during the early pregnancy, the number of oxytocin receptor is less, whereas as the pregnancy advances, the receptors concentration will increase. And how it acts, it receptor mediation, what is, these are the different mechanism how it acts. Prostaglandin protection. Okay. And oxytocin is effective for the induction of labor only when the cervix is dry. If the cervix is right, then we can administer oxytocin. But for the ripening, it is less effective. Understood? Whereas this PGE1, PGE2, this two can be given even for the ripening. But oxytocin, it stimulates the uterine contraction, even it can induce the labor, but it is less effective as a cervical ripening agent. Next is the mifepristone. So in the mifepristone, it is basically, it is a progesterone receptor antagonist. What it does, it blocks the progesterone and glucocorticoid receptors. Okay. And now the dosage is for it is it is RU 486 and 100 mg vaginally. It is available daily for 2 days. It can be given to ripen the cervix and even for the induction of the labor. Most commonly, it is not used. The most common used agents are oxytocin or misoprostol or dinoprostol, PG1 and PG. Okay. Next we are going to the surgical induction of the labor. Surgical induction. So here there are mainly two methods, that is ARM or stripping the membrane. What is ARM? Artificial rupture of membrane, and another one is stripping the membrane. Okay, so we will go in detail. First one is the stripping the membrane. In the stripping the membrane, there is chorioamniotic membrane. Okay, a membrane which is filled by both the layer, chorionic layer and amniotic layer. So what we will do, per vaginally, okay, so digital separation means fingers are used. Okay, we will insert the fingers per vaginally, and what we will do, through the fingers we are trying to separate the chorioamniotic membranes from the wall of the cervix and the lower uterine sac. So what happens? So what we are doing, using the fingers or digitally, we are separating the chorioamniotic membrane from the wall of the cervix and the lower uterine segment. And this stripping of membrane, otherwise known as sweeping of membrane, another name. Okay, this is done before the ARM, and it is simple, it is safe and beneficial for the induction of labor. Okay, the stripping of the membrane, even it can be used for the cervical ripening, also for the induction of labor. Okay, so it is otherwise known as sweeping of membrane, and it is done prior to the ARM. And what is actually the procedure? We are, through the fingers we are trying to separate the chorioamniotic membrane from the cervix and the lower uterine segment. Here you can see from the choriona, we are trying to strip the membrane. Okay. Now, what happens while stripping the membrane? What happens? There will be endogenously, there will be the release of prostaglandin from the membranes and decidua. Okay. So I think you remember. I don't know whether you remember or not. When I taught you about the onset of labor pain, there are different sites for the prostaglandin production. From various sites, a prostaglandin hormone can be produced, can be released. So it was membranes and deciduous. So whenever any irritation is occurring at the membranes, like chorioamniotic membrane or the decidua, there will be release of prostaglandin. So that will lead to the cervical ripening, even the induction of labor. Understood? That is the stripping of membrane, or it is known as sweeping the membrane. Next is artificial rupture of membrane. It is known as ARM or amniotomy. Okay, what is the mode of action? Due to that, when we rupture this, what happens? There will be stretching of the cervix. There will be the separation of the membranes. So what happens? There will be prostaglandin production. Then there will be the, as the amniotic fluid will be drained out, there will be less amount of amniotic fluid. Okay, because of this reason, there can be induction of labor, stretching of cervix, liberation of prostaglandin, and reduction of amniotic fluid volume. Okay. Now, what is the advantages of amniotomy or ARM? It is highly successful, and we will get the time, because we are able to see the amniotic fluid outside, so we can diagnose if there is any meconium stained liquor. Okay, if it is clear, no problem. If it is meconium stain, we can it is we can identify the as fetal asphyxia. Okay, then even if we are rupturing it, then the fetal scalp electrode, in order to, but nowadays it is not used more. In European countries, it is fetal scalp electrode is attached to the fetal scalp in order to know the fetal heart rate and everything. Everything will be recorded in the monitor. So if the amniotic membrane, if we are rupturing the amniotic membrane, so it is easy to keep the fetal scalp electrode. And even we can use this fetal scalp blood sampling also, we can do by after the amniotomy. Okay, so the advantages is it is highly successful, and even we are getting the chance to observe the amniotic fluid, whether it is clear or it is meconium stain. So in order to find out that, it is advantageous. And then even we can attach the fetal scalp electrode, and even fetal blood sampling can be done. The limitations: if the cervix is unfavorable, we cannot do the ARM. Okay, at least one finger dilatation should be there, and immediate benefits. So immediately after doing the rupture of the membrane, there are some benefits, like the blood. If the mother is preeclampsia, so the blood pressure will be reduced due to the draining out of amniotic fluid. Then, due to the polyhydramnios, if the mother was having some discomfort, like respiratory discomfort, distress, so that can be relieved because the fluid is being drained out. Then if there was antepartum hemorrhage, so there will be control of bleeding. Then if there is rupture placenta or initiation of, but there will be the tension, the relief, tension is relieved. Okay. Now, what are the complications or dangers or hazards of artificial rupture of membrane? Once, if we have done the procedure ARM, we cannot retreat it. Okay, because we have ruptured the membrane. Now we cannot retreat that condition. We cannot change the decision of delivery. Understood? Then, after the rupture of membrane, there is more chance of umbilical cord prolapse. Then there is chance of amnionitis, there is inflammation, infection can happen. Then there can be accidental injury to the placenta, cervix or uterus or fetal parts can happen. Even liquor amnioembolism, that is very complicated one. It can become fatal. So it is, but it is very rare. Rarely it happens. So these are the complications or dangers of ARM. Once if we have done the ARM, we cannot treat it. We cannot change our decision of delivery. Umbilical cord prolapse can happen. Amnionitis can happen. Even placenta, cervix, uterus, or fetal parts can get accidentally injured, and even it can cause liquor embolism. Okay. Next, we will see the same low rupture of membrane. It is very practiced nowadays because it is very successful. Here, what we are doing, the presenting part, what the membrane below the presenting part, or which is lying overlying the internal walls, we are rupturing it. So, some amount of amniotic fluid will be drained out. Okay. Now, the procedure is we will give the mother lithotomy position. Full aseptic technique should be maintained. Two fingers are, you can see, two fingers are introduced in the vagina and it is smeared with antiseptic ointment. Index finger is passed to the cervical canal below the internal os. The membranes are kept free from the lower segment. You can see the membranes. We are we are just we are making the membranes free from the lower segment. Then with one or two fingers, already it is in the cervical canal, a long cord, you know, the Porcher's forces, it is inserted with the blades closed, or there is one, you can see this instrument, that is a new hook. It is available that can be inserted. Okay, so one we will insert the first two fingers of the other hand, that will be inserted. So we will make all the way ready. Then the new hook for the Porcher's forces will be inserted. Okay, and if we are inserting the purchase first, it should be closed. After reaching there, after reaching to the area, then we will open it. Okay. Along the palmar aspect of the membrane, the blades are open to seize the membranes. Then it will start turned by them. What we will do, we will twist the blade. If we are using the purchase forceps, we will hold the membrane. Then we will just twist it. So what happened? The membrane will be torn. Okay. But if we are using the amniho, just we need to scratch over the membrane. That's enough. Only we need no need to do the twisting movement. Just we will scratch it. Then the membrane will be ruptured. This is followed by, so once it is ruptured, we can see immediately, we can see there will be escape of amniotic fluid. Now, if we are doing the lower rupture of membrane, if the head is not engaged, okay, in case if the head is not engaged, what we have to do, we have to, one assistance, or she has to push the head to fix into the brim of the pelvis, so as to prevent the cord prolapse. As we said, there is one danger of rupture of membrane. What can happen? There can be cord prolapse. To avoid the cord prolapse, if the head is not engaged, there is enough space for the cord to prolapse. So in order to prevent the cord prolapse, what we will do, if the head is not engaged, an assistant will push the fetal head to the pelvic tract. Okay, but if the head is deeply engaged, so what happens? There will not be sufficient space for the fluid to drain out. What we will do, we will just to the paravaginally, we will just push the head up. So what happens, there will be space will be there, so the fluid will be escaping. Okay, this too can be followed in order to the first, if the head is not engaged, in order to prevent the cord prolapse, we can just push the head down to the brim of the pelvis. And if the head is deeply engaged, what the fluid cannot be drained, So there is not space. So for that, vaginally we can push the head up. So the space will be there and the fluid will be escaped out. Okay. Now, after the membrane got rupture, we have performed the rupture of membrane. The following things we have to assess. First one is we have to see the color of amniotic fluid. We said that once the membrane is ruptured, there will be escape of fluid. Immediately, we should note the color of amniotic fluid. If it is meconium, then we can see how the color of the fluid is here. Greenish color will be there, that we have to know. Then status of the cervix. Okay, how the cervix, whether it's healthy or not, that we have to see. Then we have to note the station of head. We have to detect cord prolapse. It should not happen. We have to see the fetal heart rate. We have to then a sterile vulval pad has to be placed. And because we have performed the rupture of membrane, so there infection can happen to the fetus or even intra-uterine infection can happen. So in order to avoid that, prophylactically antibiotic can be prescribed for the mother. Understood? So after the membranes get ruptured, we have to follow or we have to assess all this. We have to assess the color of the amniotic fluid. We have to assess the status of the cervix dilatation or effacement or cervical length. All this thing again we have to see. We have to see for the station of the head. We have to detect whether there is cord prolapse or not. We have to assess we have to monitor the fetal heart rate. The sterile vulval pad has to be given to the mother so as the infection can be prevented and prophylactically antibiotic can be given. Now, what hazards, what the same things what we have said now, the complications, hazards, or prolapse of rupture placenta, injury can happen, rupture of the vasa previa, fetal blood loss, and all this we have discussed. Okay, so this is about the induction of labor. So what we have discussed today, we will just have a glance upon all the slides. Okay. So actually the induction of labor, what we are doing, we are initiating the uterine contraction, and there are various method, medical method, surgical method, and combination of method. Okay. So here you can see indications we have discussed. 1 minute. Indications we have discussed. Hypertension, yeah, hydramnios, IUFD, IUGR, or congenital anomaly of the fetus, or arachidonitis, or post-dicted pregnancy, premature rupture of membrane. So all these are the indications. Whereas the contraindications are CPD or contracted pelvis, or there is APH or vasa previa or placenta previa, malpresentation, previous cesarean section, that too classical cesarean section. All that can, in all these cases, it cannot be done. Okay. Then we have discussed about the factors, maternal factor and fetal factors we have to assess before the induction of labor. If it is in the mother, we have to confirm the indication. We have to exclude the contraindications. We have to assess the Bishop score. We have to assess the pelvic advocacy. The fetal factors, we have to see the fetal gestation age, weight, fetal presentation. We have to confirm the fetal well-being. We have to see for the lung maturity. Okay. Then in the Bishop score, several parameters are there: cervical dilatation, effacement, position of the cervix, consistency of the cervix, and then station. Then, as we said that it is modified Bishop score. So now instead of effacement, cervical length has been added. The total score is 13. The favorable score is 6 to 13. Unfavorable score is 0 to 5. If you are getting 4, 4, the score is 4, we cannot proceed with the induction. Okay. Then methods of cervical ripening, pharmacological and non-pharmacological method. Then methods, medical method, induction of labor, surgical and combined. Medical we discuss, surgical we discuss in the medical prostaglandin E1 and E2, then oxytocin, then mifepristone. Okay. Most commonly we are using is prostaglandin. That this two, prostaglandin E1 and E2 and mifepristone. This two can be used for cervical ripening, but oxytocin it has good less. It is not that much effective in order to ripen the cervix. Okay. Then then surgical method, artificial rupture of membrane, stripping the membrane. The artificial rupture of membrane, ARM or amniotomy, stripping of membrane is otherwise known as sweeping of the membrane. Okay. We have discussed all this thing. I think you have understood the induction of labor. If you have any doubt, please let me know. Okay, thank you.